Hello, everyone. I'm Daniela Filipescu, WFSA President, wishing you all a happy World Anesthesia Day 2025. This day brings our global community together to celebrate progress and recognize the vital role of anesthesiologists in safe, affordable emergency care. Our 2025 theme, Anesthesiology in Health Emergencies, highlights how essential we are in crisis, often on the front line, providing life-saving treatment. WFSA work on this year's annual theme includes focus statements at WHO meetings, new educational resources such as a new tutorial of the week package for health emergencies, a special update in anesthesia issue, and a series of webinars held over the year and also happening today, a chance to learn, connect, and share. Join the webinars. Share your stories through the dedicated photo booth and In Your Shoes campaign, and help us make the World Anesthesia Day 2025 unforgettable.
Hello friends, I'm Sheila Maitra, Chair of the Intensive and Critical Care Medicine Committee of the WFSA. Welcome to the WFSA Marathon session. We have 4 focus webinars with lectures and interactive panel discussions, highlighting the pivotal role of anesthesiologists in managing health emergencies from disaster response to critical care crisis. The sessions will explore preparedness, rapid decision-making, resuscitation expertise, and leadership of anesthesiologists as part of multidisciplinary teams in various health emergencies, underscoring their indispensable role in saving lives when seconds count. Thank you for joining.
Thank you. Thank you very much, Francis. And hand over to you, Ekta.
Thank you, Carolina. Happy World Anesthesia Day. I'm Ekta and I'm from India. I'm a member of WFSA education team. Over to you, Seda.
Thank you, Ekta. Happy World Anesthesia team. And I'm from Seda. I'm Seda Akinci. I'm from Hacettepe University, Ankara, Turkey. I'm a member of ICCM committee of WFSA. I am also on the advisory board of Hacettepe Center of Disaster Medicine Research. Thank you for joining us.
Thank you. Thank you very much, Ekta and Seda. Seda, over to you.
Yes, please. Any health emergency, whether it's a pandemic or any humanitarian crisis or any nature or man-made disaster, pushes the healthcare system and the healthcare workers to their limits, even beyond their limits. And these instances also bring out remarkable examples of resilience, cooperation, and innovation, actually.
Okay, so in next 90 minutes or so, we will explore how we can uphold safety and quality, ensure compassionate pain management, and continue education, even after circumstances are not so ideal. So before we jump into it, let me just go through the webinar housekeeping rules. So if you have a question, please jot it down in your Q&A box. The translation is available. Please select your preferred language in the setting. Certificates will be issued after 15 business days of the webinar, and the webinar is recorded and it will be there on YouTube soon. Thank you, Carolina.
Thank you very much. So we are very fortunate to have an outstanding group of experts with us today who work directly in these challenging contexts. Let's dive right in. So this is the agenda for today, and we will have 3 lectures and then a panel with 3 other panelists and Q&A at the end of the session. So welcome to our speakers. And we have now for Kathleen Ferguson, from Aberdeen, Scotland. She is the chair of our Constitution Committee. Dr. Anna Schwartzman. She is a professor in Montevideo in Uruguay, and she is a member of the Pain Medicine Committee of the WFSA. Dr. Rodrigo López Barreda, cardiovascular anesthesiologist from Chile, and he is member of the WFSA Education Committee. And to join our three speakers, our panelists, and Luiz Fernando Falcão. He is from Sao Paulo, Brazil, and he is currently the director of memberships of the WFSA. Françoise Nizeyimana, she is from Rwanda, and she is one of our champions in patient blood management. And Gauhar Afshan, who is from Pakistan, and she is member of our WFSA Pain Medicine Committee. Our next presentation focuses on something deeply human, pain management during emergencies. Today, we celebrate World Anesthesia Day, and it's not a coincidence that tomorrow, October 17, we celebrate World Day Against Pain, considering that pain relief is an even crisis situation. The obligation to relieve suffering remains central to our work. Yet limited supplies, disrupted logistics, or overwhelmed facilities often make this incredibly difficult. Please welcome Anna Schwartzman, who will explore practical and ethical approaches to managing pain in such challenging environments.
Hello, thank you for the invitation of being part of World Anesthesia Day 2025. Today we will talk about pain management in emergency. Pain is the main reason patients come into emergency department. 30 to 60% of the visits to emergency rooms are for pain, and these patients, 30% of them report severe pain. There are many causes of those pains, and we have under treatment challenge of pain in emergency department. The main barriers to effective pain management in emergency are the underestimation of pain by health providers, the fear of use opioids related to its adverse effects, the lack of standardized pain management guidelines, the emergency department overcrowding with a staff shortage that limits care capacity, and training gaps among health team members. There is also an inadequate use of analgesic drugs. Frequently, it is used oligoanalgesic with one drug and only one drug. There is also a lack of knowledge of the mechanism of actions of analgesic drugs, and the use of wrong doses, increasing side effects, or, in the other hand, subtherapeutic doses, which lead to insufficient analgesia. We have to remember that untreated acute pain is not only pain. It is also immunosuppression, prothrombotic state, hypertension, respiratory restriction, adrenergic overload, psychological distress, prolonged hospital stay, higher readmission dates, poor overall care quality, and risk of develop chronic pain. We have to start with a general evaluation of pain. We have many tools. I bring you here the PQRST tool, where P is provocation, what triggers the pain or make it better. The Q is quality, that describes the pain's nature, if it is sharp, dull, etc. The S is the severity. This is the assessed to intensity of pain using scales. R is the region, where is the pain and where it is spread. And T is the time, when it started and how long has it lasted. First of all, in the emergency room, we have to exclude life-threatening causes, because in this case, we have to act promptly and at first time. Then we will have to make a correct assessment of this pain. So we have three important facts. First is the pain duration. It is an acute pain, it is an exacerbation of a chronic pain, or it is a chronic pain. Sometimes these patients make misuse of emergency department and go to the emergency, but it is indeed a chronic pain. Concerning the pain etiology, it's important to know that it is a traumatic or non-traumatic pain, and if it is oncologic or non-oncologic. Talking about the physiopathology, we have to know if it is a nociceptive pain, a neuropathic pain, or a mixed form involving both pains. We have to put a name of this pain, and these 3 points are very, very important. Pain is the fifth vital sign requiring regular and consistent assessment. We have verbal scales where patients describe their pain intensity in their own words, and this allows us to put the pain a number that will be very important for the evolution, first to define the intensity and then to know how the patient responds to our treatment. But we also have nonverbal scales designed for patients unable to communicate pain verbally. Functional scales are very important, and we have to use it both at rest and also during movement. Regular and accurate measurements support effective pain management decisions. We will use a multimodal patient care center management in emergency. As we know, multimodal is the use of more than one drug by more than one way of administration, optimizing anesthesia, reducing side effects. We also have to include non-pharmacological therapies. We can think about making regional nerve blocks, and we have to make a patient-centered approach, tailoring the treatment plan to this individual patient to improve the outcomes. We have to make an assessment based on global status and function of the patient, using validated pain scales and making frequent reassessment to titration, analgesic drugs, and improve non-pharmacological treatment, and make it as many times as needed. Analgesic is not just the use of systemic drugs. We have to start thinking out of the box. We have many non-pharmacological or maybe drugs administered non-systemically that are very useful in treat pain, even in the emergency. Empathy and clear communication is very important. It calms anxiety and it improves patient outcomes. Apply the Reis protocol, that is rest, ice, compression, elevation for certain injuries, the topical agents, the use of mindfulness techniques and respiratory exercises, the use of acupuncture, and the regional nerve blocks. The pharmacological treatment will be based on the analgesic ladder. As you know, this ladder was first described for oncological pain, but it's very useful also for non-oncological pain. Following the analgesic ladder, the low pain intensity will be treated with non-opioid analgesic and coadjuvants. Acetaminophen is the first-line treatment in almost all pains. It can be given intravenous if oral intake is not possible. Non-steroid analgesic have a good place in acute pain, but we have to use the lowest effective dose for the shortest duration, and be aware of renal function, cardiac function, gastrointestinal risk as recent gastrointestinal bleeding, and especially in a special population like the elderly and comorbid patients. Minor opioids will be used in moderate pain intensity, tramadol, codeine, and for severe pain, we will use major opioids. Regional blocks reduce systemic drugs use and provides a very good quality of relief of pain, of control of pain when they are indicated. These are the more commonly used in emergency room. As you see, we can do it in the upper extremity, in the trunk and neck, and in the lower extremity. The adjuvants can be used at any stage. We have the subdissociative ketamine doses that provide effective analgesia in trauma and not trauma. Intravenous lidocaine could be used selectively, avoiding use in patients with structural cardiac disease. And also topical lidocaine is very effective in neuropathic localized pain and also in myofascial pain. The use of opioids should be optimized in the emergency department. We can use opioids for moderate to severe acute pain when non-opioids are insufficient as a part of a multimodal plan. Always prescribing the minimum effective dose for the shortest duration and avoid co-prescription with others central nervous system depressant. We have to monitor the patients for tolerance for opioid-induced hyperalgesia and addiction risk. We have to use prescription monitoring programs when available to track opioid use. If we have a patient with chronic pain, we have to coordinate with chronic pain management unit to avoid inappropriate opioid use during exacerbations. We have to use apply function direct anesthesia to titrate opioids based on patient response. Safe opioid use is essential to balance analgesic benefits with potential risks. These steps of multidimensional pain assessment and safety monitoring are very important to treat pain effectively. We have to make pain assessment covering intensity, pain function, autonomy, vital signs, comorbidities, and drug risk factors. Our aim is to reduce pain and improve function rather than complete pain elimination. We have to monitor safety by focusing on respiratory depression, sedation levels, and interactions with central nervous systems. We have to maintain ongoing vigilance to ensure patient safety throughout the analgesic therapy and use multidimensional assessment to support balanced and effective pain management. As I mentioned, we have many barriers in emergency department to treat pain. So here I will show you some effective strategies to enhance pain management in emergency departments. We should have analgesic protocols. If we don't have it, we can go and work to construct them. The ongoing education and training for staff is very important. We also have to have a structured documentation tool to track pain management. The promotion of empathetic communication with patients is a very, very important point, and it will be present all over the process of the analgesic treatment of the patient. We have to develop integrated protocols spanning these protocols to pre-hospital and hospital care, because sometimes these patients come from pre-hospital services, and there it is important that they also has these analgesic protocols. And of course, engage multidisciplinary teams to improve patient outcomes. I will share these practical recommendations for emergency department pain management that will help us to effectively treat pain. We will start pain management with non-opioid medication and plan a multimodal approach. We will use opioids only when benefit outweigh risk and minimum effective dose with close monitoring. We should adhere to institutional multimodal anesthesia protocols to guide treatment or make these protocols if they do not exist. Regularly assess pain, use validated scales, and frequently reassess pain. Closely monitor safety and implement programs to reduce opioid misuse. Maintain always an empathetic communication through the patient and the family of the patient care, and follow guidelines and recent clinical reviews to inform practice. If any of you have taken the Essential Pain Management course, you will have recognized in my presentation several elements of that course. This powerful tool is very useful addressing pain in all scenarios. This is the way to effectively treat pain and overcome the barriers that lead to its undertreatment. These are the bibliographic references, and thank you very much for your attention. We'll be together in a while for any questions that you may have. Thank you very much.
Thank you, Anna, for that powerful reminder that pain relief is not a luxury, but it is a matter of dignity and humanity. I really loved your PQRST approach, and indeed, EPM has made pain management very easy. Now, I'll just hand over to Dr. Carolina. Over to you, Dr. Carolina.
Okay, we'll go again with Kathleen. Lecture Safety in Health Emergencies.
Thank you very much for inviting me to join in the celebration of World Anaesthesia Day, and I'm pleased to advocate for our role in quality care and more specifically in emergency care. So, in 15 minutes, I'm going to provide a whistle-stop tour of patient safety and the vital role that anaesthesia plays in safe care. I'm going to use these 5 bullet points that are here, and it's important to recognise, as has been said before, the role that anaesthesiologists play in the delivery of quality care with their preparedness, rapid decision-making, their clinical expertise, and their collaborative leadership style. Can I have the 3rd slide, please? Okay. I'm not sure if the third, yeah, there we go. That's fine. I'm just checking it's showing properly. In order that we align our thinking on this topic, here is WHO's definition on patient safety. We're endeavouring to reduce risk and harm to patients. During emergencies, we're all too familiar with the chaos and panic that occurs with overcrowded, noisy spaces, unfamiliar teams, and poor communication and coordination of action. The magnitude of preventable harm associated with healthcare is concerning. In low and moderate income countries, as many as 4 in 100 die from unsafe care, according to WHO's patient safety. Safe anaesthesia requires a trained provider along with the appropriate drugs, equipment and facilities and trained assistance. Next slide, please. WHO states that a safe health system is one that adopts all necessary measures to avoid and reduce harm through organised activities, including leadership and culture that prioritises safety, a safety engineered work environment supported by policies and procedures, and capable staff and effective teams, engagement with patients and their carers with systems to support learning and improvement. Next slide, please. WHO published its Global Patient Safety Action Plan in 2021, providing a framework for countries to develop their respective national action plans on patient safety, as well as to align existing strategy instruments for improving patient safety. The Global Patient Safety Report 2024 is the first ever WHO report offering a comprehensive overview worldwide of patient safety implementation of policies, strategies, and initiatives. The 7x5 matrix for mapping is shown there too. Next slide, please. Healthcare mortality varies globally with higher rates in low and lower middle income countries. It also varies by patient group. The graph here shows figures for maternal mortality ratio across 6 sequential time frames, and it shows the rate is falling, but there is significant variation across regions. In 2023, WHO reported that 92% of all maternal deaths occurred in low and lower middle income countries, and most could have been prevented. The UK NAP7 project suggests that death related to anaesthesia alone is approximately about 1 in 100,000. And the ANZCA report from 21 reports mortality per million population as 2.6. And for those undergoing surgery, it's 1 in 66,000 approximately. The ASOS study, the African study of outcome after surgery, claimed the mortality in Africa was twice that of a global level at 2.1%. And the IHI in 2000 stated that perioperative mortality rate is in low and middle income countries was near 1 in 300. Mortality is greater in older patients, the comorbid patient, those undergoing emergency surgery, trauma and obstetrics, and are particularly at risk. Patient demographics are changing and impacting on mortality, but we know that the mortality rate for the young and healthy is continuing to decline. Next slide, please. Don Berwick is reported to have relayed this idiom that culture trumps strategy, and it's true. We define a positive safety culture as one where the environment is collaboratively crafted, created, and nurtured so that everybody can flourish to ensure brilliant, safe care. We create the culture by continuous learning and improvement of safety risks, supportive and psychologically safe teamwork, enabling and empowering speaking up by all. A culture is determined by shared values, beliefs, and behaviours, and it's observed in the policies and procedures designed to deliver the healthcare. In essence, it's the way we do things around about here. The impact of adverse culture on patient safety is clear to see in many reports of poor patient outcome. Next slide, please. Although it seems obvious that doctors who feel safe and valued in their work environment are likely to perform better, this report, commissioned by the UK General Medical Council, suggests practical changes like compassionate leadership, improved facilities, better team working, more consistent high-quality inductions help achieve these goals. The well-being of doctors is vital because there is abundant evidence that workplace stress in healthcare organisations affects quality of care for patients as well as doctors' health. In 2 studies, researchers found that doctors with high levels of burnout had between 45 and 63% higher odds of making a major medical error in the following 3 months compared with those who had low levels. Next slide, please. A complex system is a collection of individual entities, that's patients, staff, departments, that undertake work that cannot be fully specified or prescribed in advance. These entities' actions are interconnected so that one entity's action changes the context for the others. Healthcare has been described as having the characteristics of a complex system. A systems approach to patient safety argues that it is unexpected system interactions rather than individuals that are responsible for accidents, and safety improvement cannot be achieved simply through more individual training. Following on from that, a systems approach advocates that interventions for improvement should be focused on better design and system interactions. Person-based interventions such as retraining and local policies are less effective for long-standing change and improvement. Safety thinking has previously focused on learning from incidents, Safety 1, using a linear root cause analysis to identify causation. But if we accept the complexity of the systems we work in, then Safety 2 offers a better approach where we acknowledge that humans are the most often the reason work is completed successfully. This is the work done rather than the work prescribed. In fact, a combination of Safety 1 and Safety 2 thinking is usually required in systems analysis. Next slide, please. The healthcare environment needs to be fit for purpose. The WFSA have collated this table on level of facility described by WHO, the Lancet Commission on Global Surgery and Disease Control Priorities. They've classed them into 3 levels, 1, 2, 3, according to the care and services that can safely be delivered. Clear care pathways are needed to ensure that the right patient gets the right care at the right time in the right place. The ability to deliver care on these standards is not equitable across the globe. Facilities also need to be placed in a healthy work environment, which is one that is safe, empowering, and satisfying, being a place of physical, mental, and social well-being, supporting optimal health and safety. The safety culture is then easily achieved. Next slide, please. In the UK, the GMC provides standards for medical education and training. They set out 10 standards that organisations responsible for education and training need to meet. The standards and requirements are organised around the 5 themes you see here. Patient safety is inseparable from a good learning environment and a culture that values and supports learners and educators. Miller's triangle on the right describes the completion of training as we reach the trusted level. Here, we demonstrate the ability to deliver safe care whatever the situation or challenge. The end goal in training is capability and not simply competence. Next slide, please. The WFSA standards of care are designed to guide anaesthetists and healthcare administrators worldwide in improving quality and safety. These standards cover professional aspects, facilities, equipment, monitoring, and the conduct of anaesthesia. Highly recommend equates to mandatory standards, and they include the continuous presence of a trained anaesthetist or anaesthesia provider, continuous monitoring of tissue oxygenation, intermittent monitoring of blood pressure, confirmation of the correct placement of the endotracheal tube, the use of the WHO Safe Surgery Checklist, and a system for transfer of care at the end of the anaesthetic. The international standards represent a minimum standard and can also be used to help acquire necessary resource. Next slide, please. Knowing self. Expert professionals have the ability to act quickly in difficult and often messy situations. This requires competence built up during years of experience, internalising formal knowledge after having used it in clinical situations. It's called tacit or intuitive knowing, and it's not so much about what you know, but rather about how you know it. The advantage of basing decision-making on intuitive knowledge is that it's quick and almost effortless. Conscious analysis is slower and puts a heavy load on the working memory. The intuitive way, fast thinking, saves time and energy that can be used for conscious analysis. Slow thinking is used in complex or novel situations. Fast thinking carries the risk of spurious conclusions, and the more analytical, slow way of thinking may serve as a watchman to moderate impulsive action. Both types of thinking are burdened by cognitive biases. And in the acute crisis situation, the anaesthetist may well resort to step-by-step action plans. Resilience in anaesthesia and intensive care is the ability to manage the breadth, depth, intensity, and chronicity of the demands of the work. Resilience is a dynamic, contextual process that goes beyond the narrow concept of an individual's toughness. In supporting resilience, we should identify where there's an issue, talk about it, involve all concerned, and intervene with systems like trauma risk management when the situation doesn't resolve. Next slide, please. Healthcare today is a prerogative of teams rather than individuals. In acute care, the work is complex, fast-paced, and team members are diverse and interdependent. High-performing teams demonstrate positive effects on patient safety and staff well-being. 3 meta-analyses have demonstrated positive impacts of improved teamwork on patient and organizational outcomes. The latest in 2023 demonstrated that initiatives to improve teamwork reduce patient mortality by 28%. Common themes in good team performance are sharing the mental model, maintaining team situation awareness, building respectful relationships, and clear and concise communication. The picture here shows a model of effective team performance with the inner circle describing observable behaviours of the effective teams and the outer circle describing the underpinning requirements. Good teamwork is about maximising team capabilities so that the sum exceeds the parts. Using the shared mental model helps form a task-focused team and helps to prioritise duties, manage information, establish roles, stabilise emotions, and build confidence. Inviting team members to add models diversifies inputs, creating a better model. The greater the overlap in mental models, the more likely the team members will predict, coordinate, and adapt. Next slide, please. Clinical emergencies can be defined as unpredictable events that necessitate immediate intervention. Simulation in emergencies has been shown to improve technical and non-technical skills and so avoid patient harm, particularly with interprofessional training. Cognitive aids can improve human performance and mitigate its limitations. They support and facilitate the clinician's cognitive ability. In a recent review, cognitive aids were associated with a reduction in the incidence of missed care steps from 43 to 11%, and they decreased the incidence of errors, improved clinical teamwork skills, non-technical skills, subjective conflict resolution, and global assessment of team performance. Cognitive aids should be tested before their deployment with adequate clinician and team training. This is a slide, next slide please. This is a slide, a few screenshots of currently used checklists and crisis manual collation of emergency guidance. There are many others out there, but beta testing is not commonplace. Care is required in selecting the correct cognitive aid for the job. So in summary, the key messages I have: safe healthcare should be considered a basic human right. Safe culture underpins safe practice. Safe practice requires well-trained, capable professionals working in safety-engineered environments. Resources and facilities affect outcomes. We should be using standards of practice to deliver safe care, but also to acquire more resource. Emergency preparedness and response relies upon safe, routine practice. And emergencies increase cognitive load and demand good team working, good non-technical skills, and the use of cognitive aids. Last slide, please. Thank you all for being very tolerant of my very poor PowerPoint skills and listening to what I have to say. I look forward to joining into the discussion at the end of the session, and very, very happy World Anaesthesia Day. Thank you.
Thank you. Thank you. Thank you, Kathleen. Thank you very much for that excellent presentation. You reminded us that preparedness and safety culture are not optional. They are what holds systems together when everything else is uncertain and existent bias is right there. Hand over to you, Ekta.
Great. So now let's look at another vital component that cannot stop even during a crisis, that's education. And our third speaker will focus on education during humanitarian crisis, how we continue mentoring and supporting healthcare professionals when normal systems are disrupted. Please join me in welcoming my friend, Rodrigo López Barreda, who will share inspiring examples of how learning and professional development can continue under toughest condition. Over to you, Rodrigo.
Thank you very much, Ekta, and thank you everyone for giving me the opportunity of sharing part of my experience with you. And I'm really happy that my presentation comes after Kathleen, because I think the concepts that we're going to talk about are very much complementary. Let me know whether you can see my screen now. Can you?
Yes.
Great. So, first of all, I want to say something about my conflict of interest, but instead of actually being conflict of interest, I want to let you know where I'm talking from, my base. I'm a cardiac anesthetist from Chile. I do have both or mixed backgrounds, international cooperation. I've worked with many NGOs and academic background. I'm working in a teaching hospital in Chile. I'm a WFSA educational committee member, and I'm still working for Lifebox as an advisor. That's why I have wandered many countries for the last 10 years. And in this presentation, I'm gonna show you some definitions, very basic definitions, the main problem, why do we have an issue with healthcare in these situations, some solutions, and the role of education as a possible solution to face these problems. So, some basic definitions. An emergency, a disaster, is a situation severe enough to affect people's lives in a very severe way, and it could be both. Either a natural phenomena aggravated by human action. We don't talk about natural disasters anymore. That's the current definition. Natural phenomena aggravated by human action, or armed conflicts. Some of them are wars. Not all conflict is a war, and there are some technicalities by separating an armed conflict and a war. But for the sake of time, I'm not going to go into those details. But if you want to talk about a humanitarian crisis, we have to fulfill specific criteria. Either the mortality rate or the under 5 mortality rate doubles its previous values, or if we don't have the previous values, mortality rate is above 1 case, 1 death every 10,000 people per day, or the under 5 mortality rate is above 2 deaths every 10,000 per day. Okay, so not all emergency is a crisis. That's something that you have to keep in mind. But to show you how important these concepts are, I'm going to show this map in which all the current emergencies are depicted, not crises, emergencies. Most of the crises are concentrated in Africa and, of course, in this part of the world as well. So crises, humanitarian crises are here, but emergencies and disasters are spread all over the world. So that's why it's a very relevant topic for all of us, anesthetists in the world. What is the problem? So during one of those emergencies or crises, there is an imbalance between health needs or healthcare demands and healthcare provision. The needs go up and the provision goes down. Why? We have more patients, either trauma patients because of the war, because of whatever earthquake, or infectious disease. These conditions come very soon after the initial hit. And healthcare provision goes down because we have fewer healthcare workers. Either they are affected by the condition or they fled. There is an impact on facilities. So the hospital is destroyed or it was bombed, for example, during a war. And there is a disruption of the supply chain. So even if you have healthcare workers, even if the hospitals are there, it's really difficult to get drugs, for example. I was in Sudan a couple of months ago, and it was really difficult for us to find even paracetamol. On top of that, you have to imagine that we still have the normal burden of diseases. So we still have the non-communicable diseases there. We still have hypertensive patients, diabetic patients. And we have this important need, which is often neglected, sexual and reproductive health. And in terms of the cult context, there is a lot of discrimination often in this context, and we have to be very much aware of the cultural norms. So the role of gender, ethnical issues that may be around in this place. That's why we have this huge imbalance, and these conditions may favor one population over another one. Possible solutions, regulations. I think we have to work more on regulations. We've seen that in the current crisis in Palestine, how the humanitarian law is not very effective into getting all the supplies there. As Kathleen said, we have to work on resilience. I think we I would like to think that we learned after COVID crisis. I'm not very sure that we actually did it or not, but yeah, that's a very concept which is very much in fashion now. So, but we have to think about resilience and how can we construct better and stronger healthcare systems, not just individuals, not just thinking about healthcare professionals, but also the whole system, how we can become more resilient. And this is why education has a very significant role. And during a crisis, we have some challenges, but also some opportunities. And I think we have to be aware of both sides. Some important misconceptions. It's often said that during a crisis, an emergency, people are not thinking about learning. So the priorities are different. So we have to think about getting enough food, water, and I agree, those are the most important needs that they have to face at that time. But even in the worst situations, people want to do their best. And I think if you provide them with the right opportunities and the right circumstances, they can learn and they will enjoy of that. So it is not the number one priority, but I think learning is an important thing that we can do during a crisis. Resources, another important challenge. If we cannot get enough paracetamol or morphine, of course, it's going to be very difficult to get training material, mannequins, or whatever. Yeah, so yeah, it's a challenge. Access connectivity. So I know it's really difficult to get into a conflict zone, a war zone. That's why there are some training programs nowadays using distance delivery modes, but we're not very much aware whether the people there have access to internet. So that's why that's another important issue, access, getting there, the trainer there, or if the people have internet to access the course contents. Security, that's another issue for the facilitator and for participants as well. And we have to keep in mind those issues, but at the same time, there are huge opportunities. So one of the principles of adult education is that learning has to be meaningful. If you feel the need of learning something, if you need that some content is important for you, for your clinical practice at that time, you will be more willing to learn it. And I think the situation that we have to face in a crisis is the best example of a need. You feel that I have to learn how to manage pain, for example. I have to learn how to manage human resources. I have to improve my human factor skills. So that's why I think this context provide us with the very valuable opportunities to realize our shortcomings and then to have the motivation to be committed to a training program. It sounds weird, but I want to show you this picture. This was a course that we ran in Sudan in the middle of the war, the worst moment of the war, I would say. But yeah, so I think you can see here a bunch of people willing to learn. This was the Inspire course. And I think it was a wonderful experience for all of us, not just for me as facilitator, but for all of them. They wanted to become better clinical educators, and that's why they asked for the course. But to get there, to organize a training course in such a difficult situation, I think there are three important criteria. We have to collaborate with them. We have to know the learning needs, what they need. And actually, as I told you, I worked for the WFSA in the educational committee, have a lot of experience with different courses. So I told them, so this is the courses that I can run here. What are your needs? What do you want to have first? And of course, we went first with the EECC course, the Essential Emergency Critical Care course. We ran it 3 times. They love it. They got some practical skills to face the challenge that we were facing at the moment. It was a great course, but then they asked for other courses. So something, as Kathleen said, more on human factors. So we ran a couple of models of the Safe WAR course, teamwork and communication. That was the main issue for them. And then we ran a couple of VAS well-being courses to manage stress and to detect burnout. And I mean, run many courses in the worst of the war, and people got they were really satisfied after the courses. So we have to collaborate with them. We have to know the needs. We have to be very flexible. This Inspire course it's supposed to last for 4 days, but it took us 11 days to complete it because I mean we're running some activities and then we had to rent the shelter, so we have to be flexible. There was no paper at the moment, so again we have to adapt all the training materials to be delivered the best we could. And this is one of the most important parts. The course has to be well designed. There are plenty of training programs developed by well-intended people, but without the right skills to put together a course. And then you're going to waste an opportunity and a lot of resources. That's why I think we have to select the best courses, though, again, there are needs. And to finish, I wanted to share this picture. This seems very, I mean, like heaven, but it was in the war in Congo. So I think it's important to keep in mind that the war is not what we think it is. There are different parts of the war, and even in the worst moments, there is time for learning and there is time for enjoying sometimes something as beautiful as this picture. Thank you very much.
Thank you, Rodrigo, for the motivating talk. It's encouraging to see how your dedication and collaboration can keep education alive, even in the most difficult circumstances. We now bring together our 3 speakers with 3 more to form the panel discussion. I would like to invite Gauhar Afshan from Pakistan, Françoise Nizeyimana from Rwanda, and Luiz Fernando Falcão from Brazil, together with our 3 speakers to form the group. Together, they bring a wonderful mix of experience from clinical practice, education, and humanitarian response. Are we all together? Then let's start. I have one request from you all. For the questions we are going to ask, just answer in a minute to keep going and answer all the questions that have been asked from the audience as well. My first question would be, what do you see as the biggest challenge to maintain quality of care during a health emergency? Let's start with you, Rodrigo, as you're on the screen right now.
Okay, thank you very much. I think it's difficult to say which one is the biggest challenge. I think we have a big challenge with big problem with resources. It's really difficult to get what we need to work in those conditions. And the second biggest challenge, and probably I would say it's the most important one, is stress management. I think people feel overwhelmed quite easily, and then it's really difficult for them to think clearly. And that's why I think that the course that we ran, the Possible Being course in Sweden, was so well appreciated. I think if you provide healthcare workers with the right tools to manage their stress, everything's going to be much easier after that. And really close to that, one of the main concepts that we came up in that course was that we were not alone. So this community feeling, I think, was one of the most important things to face that difficult situation. So those 2 things, human factor skills and some specific resources.
I'm going to ask the same question to Kathleen. What do you think?
Oh, it's a great question. I think the biggest thing we need, whether we're in an emergency, or I have a grandfather clock that is chiming, I apologize. The biggest risk is not having enough well-trained, adequately staffed workforce. The workforce really needs to train together, to practice together in order to deliver safe patient care. And I think that's lacking even in routine care, never mind in emergencies. So what we have to make sure that we don't stress and lose all sorts of resilience is we need the policies and procedures within our culture. That means when we're stretched to breaking point, there's priorities in what we're being asked to do, and that staff feel valued and supported. So I think that's the biggest thing. Well-trained teams working together, supported by an appropriate culture. Thank you.
What do you say, Gauhar?
So I think the previous panelists have elaborated that, and certainly because I practice in the lower and middle income countries, so we are very cognizant of the resource allocation. And the resource allocation made the most, the difficult for us is the human resource. The trained people, the trained, healthcare and allied healthcare, because we now in our part of the world, we are focusing on the training of the allied health as well, not only the typical healthcare staff. And certainly we need to set the priorities, and in some of the different aspect is the institutional and your national some kind of a guidelines. And in some situations this is important that more than one mind that has to be some kind of a governing body governance that give the guide and the path towards that in that type of crisis.
What about you, Luiz? What did you say? Luiz?
Hello?
Luiz, you are muted. We can't hear you.
Sorry, thank you. So first of all, thank you very much for the opportunity to join you and the other colleagues here in the World Anesthesia Day. So regarding the biggest challenge, in my point of view, is the maintenance of the consistency. I think keeping standards when everything else is unstable, it's a big challenge. Because during emergence, resource, staff, communication often collapse. So the quality depends on the preparation before the crisis. So in my point of view, building resilient systems, as mentioned before, with training teams, clear protocols, and mutual trust is the key.
Françoise, what do you say?
Thank you so much. Happy World Anesthesia Day. So I think my colleagues have really touched on almost everything. So what I can emphasize on is that if you look on our low and middle income countries, where with the normal work, the normal situation, you are always having a constraint of resources, including materials and everything you can imagine, up to the healthcare providers, which is the main issue. Now imagine when there's a crisis, and most of the time, this crisis, they come without, they just, you see them just there coming without any preparation. So, and you are already having imbalance between the need and what you have. And now the need is becoming more. And you can imagine that it's not an easy situation to manage. But what people can do is always to prioritize. So you see where you need more staff, more materials, and then you try to balance so that you can limit the mortality rate. Otherwise, if you don't do that, you are going to have a high mortality rate. The other thing is that you always have also to think about education, because the few staff you have to be sure that they are equipped with enough knowledge, enough skills, but also non-technical skills, because all of these elements are going to help you to keep the safety of the patient. Yeah, thank you.
Hi, Anna. What would you like to add for the biggest challenge to maintain quality of care?
Hi.
Anna, I can't hear you.
I think she
lost the connection.
Okay. So, Ekta, I will leave it to you.
Okay, all right. So,
Hi. Hi, I'm back. I'm back. Can you hear me?
Yes.
Sorry. Can you? Yes. Well, happy Anesthesiology Day. Sorry for this. I am in the middle of a meeting. Thank you very much for the invitation. Very happy day for everybody. I think that Rodrigo and Fernando and the rest of the colleagues have said everything. I think that is two things very important. First of all, coordinated actions, protocols, and be prepared for the crisis. The preparation will never be enough. We know that when something critical happens, everything goes down. So we can prepare ourselves as much as we can, as when the crisis comes, we have some preparations. And I think for these protocols and coordinated actions is very, very important. And also what Rodrigo says, we have to take care of us, of our minds, of the health, the mental health care of all the emergency staff. This is very important because they are there and they are in a changing scenario every moment. I like a post that put the World Federation today that say every second counts, and it's real. Then we have to take care of us and to prepare with simulation, with courses, with some standardizations as much as we can, knowing that when the moment comes, we won't be enough prepared, never, but we can do the best that we can in this moment. Thank you very much.
Thank you, Anna. So thank you, panelists, for really setting up the scene for our discussion. And let me dig a little deeper into each area. Let's go to safety and quality first. And I'll just ask Kathleen to respond to this question first, and then Françoise can add if she wants to add something. So Kathleen, what do you think? How can institutions protect patient safety when systems are under stress? Under extreme stress?
Well, that comes back pretty much to the comment that I made before about healthcare being set in a culture that is appropriate with shared and valued beliefs and behaviours, and set in an environment that is safe and supportive to its work staff. So having accepted that we've got the culture, what do I think would help institutions? It's providing the resilience and support to their staff for during and after such events, the ability to debrief at the end of a really hard day, the ability to know that someone will listen to you when you have something to say. So I think, yeah, that's pretty much my idea, that bedded down with that culture, being supported, listened to, valued, heard. Yeah.
Thank you, Kathleen. Françoise, you want to add on? You're muted, Françoise.
Thank you. So I will emphasize again on, being aware. So having awareness. So if you are having, for example, depending on the crisis you are having, you have one department in the hospital which is like overwhelmed. Is the one which is like receiving all patients. Let's say emergency department. Then you know that they can't work on the normal condition they were in with the normal number of staff. And actually, you are not going to create other stuff in a moment. So that's where the analysts come and you see maybe you are having another department which you can a little bit borrow some stuff, and then you bring them in a department where you need more stuff. But again, something else. So this goes with the essential medications, equipment, and whatever. And then you whenever you have staff over there, be sure that, as I've said before, they are equipped with knowledge, skills, but also non-technical skills. Remember, you are bringing staff which are not used to that environment. And if they work in a condition where they don't understand what they are doing, they are not going to be effective, first of all, but also they are going to be overwhelmed and they are going to get annoyed. So in order to be sure that they are going to be effective, but also protect themselves, you have to equip them So training, being simulation, being case discussion, being small group discussion, whatever I think is going to be effective, but be sure that they are really equipped. That's what I can say. Thank you.
Sure. Thank you, Françoise. So if I can ask Luiz, and then probably Gauhar can add on to that. From your experience, what simple but effective measures can make a biggest difference on the ground level?
Thank you very much for the question. In my experience, daily team huddles and rapid communication channels, such as, for instance, WhatsApp groups for decision making, made a huge difference during, for instance, COVID crisis. They create alignment, reduce uncertainty, and build collective confidence, even when resources were scarce.
Thank you. Gauhar, you want to add on?
Yes, thank you very much. I think the first and foremost important thing that the preparedness is very important, that such crisis can happen anytime. So your minimum kind of education in terms of safety and quality, every employee has to be trained. It's a very simple course or education, maybe in hours, then everybody should be prepared. Now, if I talk about my personal experience, I have faced two major emergency. One is about the mass casualty after the bomb blast. Unfortunately, at that time, there was so much terrorism, and I have seen them. So, but I think that at that kind of a thing, when we know that this mass casualty is here, then the briefing and debriefing really works. And later on, when crisis is over, then we as institution, as far as a national, we make a guidelines that if something happens in future, what we should do that. So some basic learning from your own experience, learning from your own environment, that is one of the basic thing. One has to be very open that we have to learn from own experience. Regardless, we have the first line kind of a guidelines available, but sometimes in crisis situation, the resources limitation, and sometimes even you're overworked, you're limit your work hours, all these things sometimes is very difficult to make things possible. But I think the briefing, debriefing, learning from your own experience, and writing a small, simple guidelines, not that a very hi-fi guidelines that if something happened, what should we do? Because, for example, in COVID time, we have, if you see that initial 2 months are different from the next 2 months, because in the initial 2 months, then we sit together, we find our own flaws, we find our own problems, and then the next 2 months were better. So learning from own experience is one of the way. Then one has to be open and then try to see how we can brief and get debrief the other part of the team. And communication, as earliest mentioned about that, that's the key to success. Communicate.
Thank you. Over to you, Carolina.
Okay, maybe Gauhar can go with this. What creative or low resource strategies have worked for providing pain relief when supplies are limited?
Okay, so I think again the preparedness that your institution, the majority of the employee must have, and we are actually promoting in our institution that as we are promoting the BLS and that kind of a thing, or ACLS, that kind of a thing, we have to certify everyone EPM. And which certainly we try to make the EPM simple at our local, context. So when the person, is kind of having understanding of basic understanding, then assessment, reassessment, and the triage. Because if you have a limited resources, sometimes you have to do the triage as well. And the triage in pain assessment, pain management is not a new idea. We have to certainly decide, especially, again, I was just mentioning about during the COVID, we are able to manage even the cancer patient, the chronic patient, not only the emergencies, we are handling that, but certainly we have to do triage for what patient we needed to them. So certainly in country like ours, where we should not only rely on the narcotics. I believe that the medication like ketamine, simple medication like, paracetamol, lidocaine, then make a multimodal approach, and the Reis, that the rest eyes, these kind of elevation, compression, these kind of a thing are under utilized. So if the resources are less, then the first thing is education. Then the pain assessment should everyone in the institution should learn how do basic pain assessment should be done, and then the triage to do, and then the limited resources can be used. So in our part, majority of our people now EPM, even the pharmacists are the EPM certified, so they don't know that how to do that. And we are also rely on a very basic regional blocks, because some advanced regional blocks we need ultrasound, everything. So we also train the people for small regional blocks that can safely be done, and then provide analgesia without, if you don't have a narcotic. So multimodality, pain assessment, triage, and the other drug which are not being utilized in our part, like ketamine, is underutilized. And it is available. So if you don't have a narcotic, and in our country we don't have a narcotic, we are relying on these kind of things.
Thank you, Gauhar. Rodrigo, how can we better balance regulatory controls with the urgent need for access to essential pain medications?
I think that's a very difficult issue because it depends on the will of the policymakers. So I think it's really important to have the right skills to talk to them. And I think that's a very big problem because we know how to talk to each other, our colleagues, we know how to talk to our healthcare colleagues as well, but talking to policymakers, I think that's something we don't know, we don't master. I think that's one important issue. And the other thing is, I think the WFSA has a role in that. This advocacy power, it's important to convince decision makers that it's important for us to have some very essential drugs to treat these patients.
Thank you very much. Over to you, Seda.
Again, I'm going to ask to Rodrigo, how can we better support local teams to lead training and decision-making during crisis?
I think the figure of a local champion is key. All the training courses that I've seen, which are effective and sustainable, all of them have a local champion there who is in charge of organizing the course and making all the modifications that the course might need. I'm thinking about Burundi, for example, or Rwanda, many countries where you know who's going to be there. And then with this champion, you can work together and we can adapt the course and make it more suitable for the context. I think that's one important strategy. Another thing is to have blended teaching modalities. So face-to-face, it's really important. Online courses, of course, they're amazing, but most of the time they're not enough. So if you can have like a blended course, some online component with the content, and then having a face-to-face time to interact, to talk to each other, that's amazing. And I think finally, it's really important to have interdisciplinary training courses. If you want to, let's say, as Kathleen was saying, if you want to run a course on mass casualty incident, just to an anesthetist, it's pointless. The whole team has to be in the same page. We all have to have the same language, and that's why it's so important to train the whole team together. Those, I think, are the most important keys.
My other question goes to all of you. I would like to ask about your country's curriculum of medical faculty, faculty of medicine, and anesthesiology residency. Do you have disaster medicine implemented in these curriculums? Do you have it, Rodrigo?
No, in Chile, it's not part of the curriculum in Chile. But I think because of the earthquakes, it's part of our culture. So I think every Chilean has some knowledge on how to handle those situations, the basic knowledge, and I think that's important as well. So not just training healthcare professionals, but the health population, they have to know where to go and how to behave. And I think all Chilean citizens have that knowledge, but in our curriculum, it's not explicitly there. We don't have any training on surgery, for example, or how to handle mass casualty incidents, for example. That's something that we have to put in our curriculum.
At least not in mine.
I'm sorry?
Not in mine.
Yeah, we
Not
don't
in my
have as well. Yeah, we don't have as well. But what I have found is that when people are at work, they have this regular training about disaster management. Yeah.
What about Kathleen?
So I'm not aware of it. I know that in the curriculum we have a significant amount of training around about leadership and management and setting culture and safety. So I was actually quickly having a quick look to see if in our practice standards there's any mention of disaster planning and preparedness. You'd think after COVID that we would all have it and that we would all be ready, and things happening around about the world, that we would all be ready. But I think we're so busy trying to do the day job that we're not really looking up to see the future, to see what's coming. So in the next 2 minutes, while I'm off air, I'm going to have a look and see if we do actually have disaster planning, but I doubt it.
What about the others?
Unfortunately, in Brazil, we don't have the disaster or mass casualty in the curriculum for the anesthesia. 15 years ago, the Brazilian Medical Association is starting a program about training for disasters from the basic to advanced, but unfortunately, this didn't moving forward to be included on the curriculum, not only for anesthesia or the surgery or the specialties, unfortunately.
Anna, what about you? What would you say? Anna, you are muted again. Anna, we can't hear you.
Yeah.
Okay.
No. In Uruguay, we don't have natural disasters. We don't have any protocol. We are a very, very quiet and very, very small country.
No. What about Pakistan?
Okay, so in anesthesiology training, which is a 4-year program, we allocated 3 months for all residents to kind of emergency rotations. In emergency rotation, there are variation. We try to, because we, in our part of the world, we face mass casualties after the bomb blast and things like that. So our residents are, in curriculum, it is also written that the 3 months they have to work in emergency for handling that. But it is not necessarily that during their rotation they face these kind of a mass casualties. So sometimes we just, to cover that, we offer some workshops, but basically in written form of the curriculum, the 3 months they have to do these kind of a trauma emergency that can be included the bomb blast or earthquake type of natural disaster. Okay. Out of 4 years.
Ekta?
No, we don't have a formal, curriculum, but as Dr. Gauhar said, our residents do go to emergency, but I doubt they see so regularly. So, no.
Nobody has it, I guess. So it's your turn to go on, I guess.
Right. So, yeah. So now let's move on to collaboration and future. And I have my first question for maybe Dr. Rodrigo, you can start off with. How do we ensure safety and ethical standards which are not compromised in a fast-moving emergency?
I think we have to be flexible. That's one of the most important things. But in order to be flexible, it's important to have some skills. So I think, again, prevention or preparation is important, and talking not just about the technical skills, but also this teamwork, communication, and ethical standards. I think many doctors have not the right training and those things, and that's why during the situation they face a lot of moral distress. If we equip them beforehand with the right skills, I think all those issues would be prevented. So yeah, education, training, I think that's the most important part.
Absolutely. So if I can ask Dr. Kathleen, What message would you like to give to younger professionals who may find themselves working in these situations in future?
Our younger colleagues finding themselves dealing with a mass disaster or a demand for care that outstrips their ability to deliver it. I would suggest they need to stay grounded, look back, fall back on the quality of training and education that they've had. And it was just when I was listening to the reply there, I think reminding themselves that they're required to deliver patient-centered care. And I think if the patient, we can only ever look after one person with our one set of hands at any one time. And so at that point, the person you're caring for in terms of safety and ethically is the one that you're looking at. If they're at the center of what you're doing, I think safety and ethics are assured. And I think, you know, if we're confident that we train people properly and that on Miller's Triangle, we're turning out people who are trusted individuals who are capable, rising to the challenges and the stresses of modern healthcare, even in health emergencies, then I'm sure they'll do us proud. That was the other thing I'll tell them. I'll be proud of you.
Thank you. Thank you so much for that. So now I'll hand over to Seda. We have some 13 questions by audience. If you want.
Just ask one, a recurring one actually. I'm going to ask it to Anna because it's about pain management in addicted patients. Anna, what do you think of pain management in opioid addicted patients?
Oh, well, this is a great issue, to talk a lot. But I think one message just to put this huge issue in one sentence is that also addict patients has the right to have pain. So we don't have to make them suffer pain only because they are addicted. We have to be careful. We have to look for help. We have to know great things about the psychoactive drugs or the most common drugs that could be used. If it is an opioid addiction, it's another issue. But I think that the thing is we have to use always the multimodal concept. That is very important. That we have many tools, as I said in my speech. A lot of pharmacological tools and non-pharmacological tools that can be useful also with addicted patients, and also the regional techniques. But I think this message, even if the patient is an addict, it doesn't say that he has no pain. He also has the right to have pain. So we have to be as smart to treat his pain as we did it with other patients. We have to make some considerations. Of course, the patient addicted will have more risk. We have cardiovascular risk for the use of substance that could help, that could hurt heart and other issues, and maybe we should ask for help, but we should to treat the pain of the addicted patients.
Thank you, Anna. I will.
Oh, thank you.
Carolina?
Yes, thank you very much. I think we all agree this has been a rich and inspiring discussions. A lot of questions from the audience related to pain management and regional anesthesia. So I know that we will reply to these questions afterwards. Across all the topics, safety, quality, pain management, and education, one message stands out. Even in emergencies, our professional and ethical standards must remain strong. Their creativity, collaboration, and compassion we've heard about today are exactly what keep healthcare systems resilient and human in times of crisis. These topics are more you're invited to continue deepening during our World Congress of Anesthesiologists in Marrakech 2026. And that will be, and let me share with you, because we are very, very proud of our World Congress of Anesthesiologists in Marrakech 2026, April 15 to 19. Please join us there. We still have early bird registration, and the program is excellent, the scientific programs, and we have also social events. It will be a global impact event. So, and before closing the session, we will present the World Anesthesia Day video, which is a mix of clips of anesthesiologists just doing the things we do during our practice. It is intended to show, and Francis will share it now,